to you, Dr. Ahmad. So yeah, as Dr. Ahmad said, yeah, I'll be talking to you guys all about sort of the development of this multidisciplinary cardiogenic shock team model that has sort of been implemented throughout many institutions across the country, and sort of how it came about, and also briefly touch on our plans for a cardiogenic shock team here at Yale. So just to start out with an outline of my talk today, we're going to go through the background of the management of cardiogenic shock that has led to the development of cardiogenic shock teams. I'm going to review a little bit of existing data that exists on cardiogenic shock teams and also review plans for a cardiogenic shock team here at Yale. So to get started, as you all know, the very simplistic version of what cardiogenic shock is a state of low cardiac output, usually in the setting of an acute insult, whereby cardiac output decreases to the point that you have a decrease in systemic blood pressure, which leads to a compensatory vasoconstrictive response, subsequently worsening cardiac output, and in a sort of feedback loop results in multi-organ dysfunction, and if not intervened upon, that will ultimately lead to death. So looking back, when cardiogenic shock was sort of more first initially described back in the 70s and 80s, mostly seen in the AMI population, shock was associated with an extremely high mortality rate of up to 70 to 80%. So to address this, these very poor outcomes, the shock trial was designed in the early 90s to compare the strategies of emergency revascularization for acute MI shock to those of initial medical stabilization. And the primary outcome for the shock trial, as you all know, was to look at 30-day all-cause mortality with revascularization demonstrating for this endpoint a 9% improvement in all-cause mortality at 30 days, though this did not meet statistical significance. When they looked at a further time point, that of 6 months, mortality was significantly improved with an immediate or emergent revascularization strategy with a 13% improvement in mortality. And this then sort of ushered in the era and the mainstay therapy for AMI-driven cardiogenic shock to provide immediate revascularization. And since on the topic of revascularization, I also mentioned the culprit shock trial, which occurred nearly 20 years later, that compared culprit only to multivessel PCI during the index revascularization of patients presenting with AMI-driven cardiogenic shock. And this study, they demonstrated reduced mortality in the composite endpoint of death and renal replacement therapy at 30 days with culprit-only PCI, and additionally showed that the individual outcome of all-cause mortality at 30 days was also reduced with culprit-only PCI, with the option to subsequently perform a staged procedure afterwards compared to an initial multivessel revascularization strategy. Though despite these improvements made in shock mortality among the AMI population, mortality even of the AMI shock population remained extremely high in the 40, 50% or even higher range, depending on the study that was looked at. And there also remained very high mortality among patients who did not have AMI-driven cardiogenic shock. Thus, in an attempt to further improve the mortality, providers really looked to mechanical support devices, the first of which was the intra-aortic balloon pump. The balloon pump was used for many years before it was formally studied in the mid-2000s for AMI shock, when it was studied in the IABP Shock 1 and IABP Shock 2 trials. In these trials, it was seen that the intra-aortic balloon pump really made no improvement in 30-day mortality, and thus guidelines have recommended against its routine use in the uncomplicated AMI population. Interestingly, and even prior to those two trials, much of the failure to improve outcomes seen with the intra-aortic balloon pump was felt to be due to its limited ability to augment cardiac output, which led to a very rapid expansion of mechanical support devices in the ensuing years and even years prior to those trials being performed. And though most of the studies regarding the use of these other devices have been mostly observational and with significantly mixed results, there are a few, those small population randomized trials that do exist, all of which do include fewer than 50 patients, which can be seen here. And on a meta-analysis of these trials, despite these devices providing more cardiac support, they individually and collectively have failed to demonstrate improvements in mortality when used in a routine, regular manner. Most recently, just to mention, there was the ECMO-CS trial, which was just recently published in Circulation this year, that looked at the utilization of immediate or non-immediate VA ECMO for patients that had stage D or E deteriorating cardiogenic shock among 117 patients from the Czech Republic. In this randomized trial, early or immediate initiation of VA ECMO in these deteriorating shock patients did not demonstrate any difference in mortality, though there was a very high rate of crossover within this population, with almost 40% of patients in the non-immediate ECMO group subsequently going on to ECMO. And while this study did not demonstrate significant improvement, there are currently 4 ongoing trials of ECMO in the AMI shock population that are ongoing, including the EuroShock trial, Anchor, the ECLS shock, and the Danger shock trials. So as a result of these negative trials, there really has remained minimal improvements that have been made in cardiogenic shock outcomes, with hospitals seeing consistent in-hospital mortality rates that have ranged between 30 and 60%. And among the AMI population specifically, cardiogenic shock has continued to be the #1 cause of mortality and affecting between 40 and 50,000 patients within the US annually. So why has mortality remained unchanged despite over 20 years of advances in medical therapies, revascularization, temporary hemodynamic support devices? Clinicians were asking, why are we not seeing improvements among these cardiogenic shock patients? And in thinking about this, there began to be general recognition that there was significant complexity to each individual patient's case, not only due to the unique phenotype or pathology that was displayed or causing patients to have shock, but also in the baseline characteristics of these patients. Further, we saw that there was significant variability in the way shock severity was being assessed, as well as the variability in utilization of Swan-Ganz catheters and the assessment of patients for exit strategies before mechanical circulatory support devices were deployed. All of which, coupled with this rapid expansion that we saw over the last 20 years in therapeutic options, has led to very significant widespread variability in the care of patients, not only between institutions, but also within institutions. And these challenges and complexities not only led to the variability in care, but also likely have impeded time-dependent decisions being made for these patients, which subsequently has led to a lack of improvement in outcomes in this population. Just to further explore some of the challenges facing those caring for cardiogenic shock patients over the past 20 years, I wanted to first look at some of the changes that have been seen in patient complexity. This data here comes from CICUs from 2007 to 2018. It's overall quite representative of the cardiogenic shock population, and it illustrates a decline in sort of classic, isolated, uncomplicated ACS. And it also notes that there has been an significant increase in baseline comorbidities in patients with cardiogenic shock, including increases in chronic kidney disease and pulmonary hypertension, among many others. This study also showed that there was increased rates of acute organ dysfunction, including 2-fold higher rates of multi-organ dysfunction, respiratory failure, acute kidney injuries, and a 5-fold increase in liver failure among the cardiogenic shock population. And with these increased in comorbidities, it's not unsurprising that with it comes an increase in mortality. So additionally, in addition to the increase in comorbidities and the increase in acute failure, organ failure seen in the cardiogenic shock population, it's also recognized that patients that were presenting with cardiogenic shock were not just presenting with isolated acute MI, acute de novo heart failure, and acute on chronic heart failure, but were presenting with many, many other shock phenotypes and etiologies of shock, which include severe valvular and multivalvular disease, COVID myocarditis, peripartum cardiomyopathy, SCAD, stress cardiomyopathy, and tamponade and pericardial diseases, high rates of arrhythmia, including ventricular tachycardia, ventricular fibrillation, and atrial fibrillation. We're seeing higher rates of multivessel left main and CTO disease among patients with cardiogenic shock. There's higher rates of patients presenting with transplant rejection, chemotherapy and immunotherapy-related cardiomyopathies, AMI-related mechanical complications, as well as patients presenting with pulmonary hypertension, pulmonary embolisms, cardiac arrest, and up to 20% of the cardiogenic shock population now is showing evidence of mixed shock with a distributive component not entirely attributed to sepsis. We additionally see that these patients are having other significant critical care needs, including extreme ventilatory requirements, all of which makes caring for this patient population exceedingly complex. So to combat these complexities that have been seen and that have evolved in the cardiogenic shock population, between 2010, there began to be this recognition that a multidisciplinary shock team would really be needed to address all of the different aspects of care for these patients. And subsequently, centers really began, who were early adopters of this cardiogenic shock team, began to publish on what were the key roles of providers for these shock teams and what was the role of this shock team. And what they included was that a shock team should provide early identification for patients with cardiogenic shock. They should be involved in the assessment of cardiogenic shock, both the phenotype, defining the severity, and identifying shock modifiers such as respiratory failure or arrhythmia. They also have roles in assisting in determining the need and candidacy of cardiogenic shock patients for medical therapies and support devices, with the goal of matching the patient's physiology to the growing list of available interventions, including revascularization strategies, mechanical support devices, and other critical care needs, to list a few. The cardiogenic shock team also has the role of helping determine exit strategies if cardiogenic shock patients are going to have mechanical circulatory support deployed, and also facilitate the deployment of these mechanical circulatory support devices, all of which this should be done in a time-sensitive manner before irreversible injury occurs. And with this, the teams described sort of the optimal makeup and roles of these multidisciplinary teams, which are largely comprised of critical care cardiologists, interventional cardiologists, advanced heart failure cardiologists, and cardiac surgeons, which each then individually bring key clinical expertise to allow for the appropriate management and quick management of this complex patient population. And along with this came the recognition that there was also a need for a standardized risk assessment tool for these patients, and thus the SCI shock stages were developed in 2019 and have been further modified over in the coming years to better define these patients and also to follow the progression of these patients as they quickly move from different stages so that we can more uniformly characterize patients. And subsequently, with this development of this risk stratification tool, the SCI shock stages, there have subsequently been these have been very well validated in recent years. So we now have a means of communicating both the severity of patients' cardiogenic shock and with it, the associated mortality. So To date, there have been a few studies that have looked at improvements made by cardiogenic shock teams, though these studies remain observational. They nonetheless have shown very significant improvements in cardiogenic shock outcomes. The first of these studies was by Tarani et al. In 2019. There was 204 patients included in the study, and it demonstrated an improved 30-day survival for cardiogenic shock patients, where they took a pre-existing population in the year prior to the implementation of a cardiogenic shock team and found that only about 47% of patients identified with cardiogenic shock would survive. And in the subsequent years, they demonstrated significant improvements in cardiogenic shock outcomes with almost 60%, and subsequently over 75% of patients having survived after being diagnosed with cardiogenic shock. Also in 2019, there were two additional studies, a study by Talib et al., in which they described outcomes among patients with cardiogenic shock that were refractory to vasopressor therapies, both before and after implementation of the cardiogenic shock team. In this study, they demonstrated, again, improved 30-day mortality even after multivariable adjustment, as well as improvement in in-hospital mortality from 61% down to 48%. Finally, in 2019, Basir et al. From the National Cardiogenic Shock Initiative, using over 37 sites, described outcomes from their initiative and showed that utilization of a specific shock protocol, with MCS being deployed primarily for before PCI in the AMI cardiogenic shock population, was allowed for achievement of a 28% in-hospital mortality, which is significantly reduced from their pre-implementation mortality of around 40 to 50%. The most recent study that has looked at the implementation of a cardiogenic shock team, and I think this is really probably the most impactful one, is a study by Papalos et al. In JACC, published in 2021, that compared outcomes among cardiogenic shock patients with and without shock teams, and found a significant reduction in CICU mortality among over 12,000 patients. Further, in this study, shock team centers were shown to be associated with higher pulmonary catheterization usage, but interestingly, lower overall MCS usage. However, when MCS was employed, they did typically employ more advanced MCS. Important to note from this study, the centers that had shock teams did report and did demonstrate faster time to pulmonary catheter insertion. They did show less mechanical ventilation following shock diagnosis, and there were fewer patients with cardiogenic shock that required renal replacement therapies. And these patients also went on to have a shorter length of stay in the cardiac ICU. So as a result of these studies, we've seen a significant evolution in guidelines for cardiogenic shock with regards to cardiogenic shock teams, which were first initially mentioned in any guideline back in 2017 when an AHA scientific statement was made on the contemporary management of cardiogenic shock. Within this, it cites the consideration for the use of a multidisciplinary cardiogenic shock team for the coordination and delivery of care, though it did note that there was no data at the time to make a formal recommendation for this. Due to the general complexity of patients, it was felt that this was in general in the best benefit of patient care, given mortality otherwise had been quite stagnant. Subsequently, a 2020 ESC position paper or position statement on AMI cardiogenic shock also mentioned the use of a standardized team-based approach and stated that it may translate to improved outcomes as a result of those 3 studies I had mentioned that were published in 2019. Following this, in 2021, the ESC heart failure guidelines noted that the unselected use of mechanical circulatory support for cardiogenic shock is not supported and should require specialized multidisciplinary expertise. In 2021, the AHA had a scientific statement on AMI shock complicated by in 2021, the AHA had a scientific statement regarding AMI that was complicated by cardiogenic shock, and again, made a statement to recommend a multidisciplinary team to help coordinate early assessment, device selection, and the optimization of care for AMI cardiogenic shock patients. Then, following the study, which I had most recently mentioned, published in 2021, it was a much larger scale study of over 1,200 patients. The new heart failure guidelines that came out in 2022 from AHA, ACC, and HSFA noted that actually made a 2A level evidence B recommendation that a multidisciplinary shock team should be utilized in the management of patients who have and develop cardiogenic shock. So an important note on these teams that I mentioned previously regarding their structure is that there is significant variability in the function and the processes that are utilized by these teams. Some teams utilize a leveled activation process versus a process which involves an entire team of all of the providers right at the start. With these leveled processes, they typically have an initial presentation phase where it may just involve a fellow and the CICU attending. And then depending on the acuity of the patient, they would escalate it further to involve the cath lab and subsequently the cardiac surgeons. With this leveled approach, there's typically more activations for lower acuity, and it has some benefits in that it may lead to earlier activation, but it can also lead to multiple discussions prior to initial therapy being delivered and potentially therefore some delays. Whereas other teams sort of employ a more full team approach where all cardiac providers are there from the start. This allows all providers to be there, a single discussion to happen, but does have the drawback of sometimes patient acuity may not be to such that all members of the group are required to be involved in the discussion. Additionally, cardiogenic shock teams have employed various algorithmic and non-algorithmic structures with respect to device selection. Those that are more algorithmic employ a fairly standardized approach to if you have a certain degree of shock, you should use XYZ advice, given there are a few devices. This overall is the model employed by NCSI, but does have challenges in that it's very difficult to address patients on a more individual scenario basis and may in some circumstances lead to inappropriate device selection, especially when you're looking at managing the entire cardiogenic shock population, not just the AMI shock population. And as a result, many of the more recent teams, cardiogenic shock teams that have been developed, have employed sort of less algorithmic approaches that allow better integration of all of the individualized patient data and hopefully leads to better device selection just based on the expertise of the shock team providers. However, there is potential for more variability in device selection and management of these patients because of this. However, despite variability seen in the shock team structures, they all really keep the same central themes, and that is of a multidisciplinary team that involves interventional, advanced heart failure, cardiothoracic surgery, and cardiac critical care providers. It is focused on early recognition and assessment of patients, all with the goal of providing expedited management with vasoactive medications, revascularization, and MCS when appropriate. So now I'm just going to shift and talk briefly about the plan to implement a shock team here at Yale itself. So I have been working with a multidisciplinary group here comprised of the cardiac surgeons, the CTICU attendings, these are CCU providers, as well as the cardiac interventional team and the advanced heart failure teams to help work and implement a cardiogenic shock team to improve our outcomes here at Yale. So just looking at a preliminary look at what our shock outcomes look like at Yale in the past year. This is just sort of preliminary data from 2022, but it shows that when we looked at the population of patients who had cardiogenic shock and received a mechanical circulatory support device, we see that we have a mortality between 50 and 60%. The one that we had seen was about 50% for the past year, which is similar to the prior years as well, and that we're seeing a right heart cath utilization rate of approximately 47% prior to mechanical circulatory support devices being employed. So to improve our outcomes, we did develop this working group, as I mentioned, with the goal of developing a multidisciplinary team to expedite discussions regarding the management of patients with cardiogenic shock and to help facilitate timely and appropriate interventions for these complex patients. So who is this team? This team is developed, the team that we developed was comprised of 5 specialties that are utilizing existing provider roles. This includes interventional cardiology, which will mirror the STEMI process. So it would be the STEMI provider that would be the member of this team. It also includes advanced heart failure, which will utilize the heart failure 1 attending, or listed in QGenda now, the transplant LVAD attending. It also involves the on-call or current cardiac critical care attending, the CICU attending. It involves cardiac surgery, the attending that's on for transplant, heart failure, or shock, as well as the cardiothoracic ICU intensivist, the CTICU providers that are on as the admitting attending in the CTICU. So how we're planning on rolling out this team, we're planning on an initial pilot phase that will occur just within heart and vascular center units during daytime hours from 8 to 5, 7 days a week. This likely will go on for a month or two so we can work out kinks. And then we will move on to a 24/7 model. And then as that gets going, we will then look to move throughout the Yale New Haven Hospital at the York Street campus, as well as including the St. Rayfield campuses, and eventually expansion to affiliate hospitals within the Yale Health System. So just to look at how this shock team activation process is going to work, there's sort of separate processes, although they're very significant overlap in the cath lab and outside of the cath lab. For the in-cath lab process, when patients who develop cardiogenic shock in the cath lab when they're identified, the plan would be to proceed with evaluation of hemodynamics via right heart catheterization, potentially as well assessing LVEDP and obtaining a stat echo when necessary. And if then patients are demonstrating evidence of cardiogenic shock based on their hemodynamics, we would then activate the shock team. It's important to note that.
Do you have an idea of how often we do that in patients who are found to have cardiogenic shock during their hospitalization?
So as far as in the past year, we had about 85 patients in the past year that at least had a mechanical circulatory support device employed. So this is a like a 2-time-a-week event. Although as we get this team going, I expect there may be some slight increase in frequency, as some patients may not require mechanical circulatory support. But overall, it's probably 1 to 2 a week that end up requiring a mechanical circulatory support device. Also, it's important to note, just if there are patients that have severe peri-arrest shock, that there's no need to proceed initially with a right heart catheterization, and that the shock team should be immediately activated prior to obtaining hemodynamics. And that in settings when there are patients with more borderline shock, and when there's an unclear need of whether the full shock team should be activated, the CICU and heart failure attendings are also available to help discuss patients. So just to be familiar with what the process is outside of the cardiac catheterization lab, when there is a patient that develops a clinical concern for cardiogenic shock, whether that be in the CCU, on the floor, or another location, It would initially start with a primary assessment by the cardiology fellow and attending, which after their evaluation, evidence of cardiogenic shock is present, they would then work to expedite right heart catheterization, stat echo, and if possible, assessing central venous SATs. And if afterwards hemodynamics are consistent with cardiogenic shock on discussion with the primary team, the cardiogenic shock team would be activated. So,
Alex,
yes.
Could you walk us? I think a good majority of the shock patients we have who come in with acute coronary syndrome come in with a ST elevation MI or something like that, and so they arrive in the cath lab with an infarction and in shock. We obviously have to work to open up their vessel, et cetera. So how do you imagine, right? The patient arrives in shock, on pressors, cath lab is activated. How do you actually envision this process taking place? Because it's also taking process in parallel, or maybe it's in sequence with us working to revascularize the patient, et cetera. Are we waiting till we've done the whole PCI to call them? Is it the shock team's activated as we're doing the PCI and coming in? But because that's really, I think, what a good number of these patients for the group on the phone here is.
Yeah, exactly. And I think that there's going to be some variability in when the appropriate time is to activate for these patients. So there may be times when activation is appropriate in the emergency department on the initial evaluation by the cardiology fellow when there's concern for a mechanical complication, or if the STEMI diagnosis is somewhat unclear, but they are presenting in shock, in which case it may be appropriate to activate the team down in the emergency department at the head of the cardiology fellow on discussion with the interventionalist. As far as most patients, though, however, will be in the cath lab. And I think that depending on the clinical situation, it is up to the interventional provider whether they would like to proceed with activation of the team immediately on arrival when they're showing evidence of significant hemodynamic compromise, or if it should occur after coronary intervention or after hemodynamic assessment. I think that in general, the sicker the patient, the earlier this team should be activated so that they're aware and ready to intervene for them. So I would say patients that are on multiple pressors that you're considering a support device immediately prior to PCI or coronary evaluation, that I would consider activation of the team right up front when that patient arrives to the lab. And then in the setting when patients are more stable and you have time, but they may be requiring significant pressors, when there's time to acquire hemodynamics and or perform coronary intervention, I would then consider activating the team after hemodynamics are assessed, as then we'll be able to sort of determine the severity of the shock and the trajectory of the patient. Does that answer that question for everybody?
I mean, a little bit. I think it's important, right? Patient comes in with the inferior and anterior STEMI and is on 1 or 2 pressors and is getting fluids and has a systolic pressure of the 90s. I think there are 2 options. There's option 1, bring him into the lab, plus minus a balloon pump, intervening, as we standardly do, see how the patient does afterwards, ship them up to the CCU and decide if they want to activate the shock team to see how things are, since now the patient has a balloon pump and other things in, or activate the shock team so that as the interventionalist is perfusing it, the shock team is involved. My worry is that if you're asking the interventionalist to activate the shock team after they've been working for an hour and a half, and then wait for this shock team to all arrive in the middle of the night or put something together, there's going to be a low threshold that interventionalist really wants to spend the next 2 hours waiting for people to arrive and discuss and do this, having just been working on this patient when it could have started a little earlier.
Oh yeah, 100%. I think that in that situation where patients are very sick up front, hypotensive on multiple pressors, that setting is definitely the setting where there should be immediate activation of this team. I think that when there's patients that are maybe more stable and are only on a low dose of pressor, that would be a setting when, if there is clinical concern or there is later evidence of shock, that it would be later activation. But in the setting of multiple pressors, in the setting of consideration of MCS, I think that the team should be immediately activated, as you mentioned, in that setting. I think one of the struggles is it's difficult to be too algorithmic on exactly what time we should activate for these patients. And I think that that's one of the hopes of this talk today, is to sort of have that discussion. But in general, earlier activation is our goal. And in patients that do display evidence of cardiogenic shock, we are hoping that this team is going to be a resource, and a resource that can help immediately early on in these patients to improve their outcomes. All right. So I will continue on. One point I did want to make is in regards to patients that do experience cardiac arrest when they're being evaluated for cardiogenic shock, is that if they do have a cardiac arrest and are considered a candidate for ECMO or ECPR, that we would then refer to the ECPR process, although there is significant overlap in the providers that are involved in ECPR and with the cardiogenic shock team, as it's a continuum. So just to go briefly through the mechanics of how this team is activated. So this team is activated through Y-axis via a phone call and then asking for the Yale New Haven cardiogenic shock team. What will then happen is Y-axis will facilitate a conference call with the shock team providers, as I mentioned previously, for the interventional cardiologist. If the patient is not already in the lab, it would be contacting the board master or charge nurse, similar to the STEMI process. And then on call, once we move to a 24/7 model, it would be contacting the on-call STEMI provider. The primary cardiology team would then have a brief discussion of the clinical scenario of the case, and then after which there would be an in-person assessment by pertinent team members following this brief assessment and call. Just to look at what we feel should be involved in a complete shock team assessment and what it should consist of. The shock team assessment would consist of, one, assessing the type of shock, whether it's purely cardiogenic, whether there's a mixed component or it's purely non-cardiogenic, determining the shock phenotypes, whether it is ischemic or non-ischemic, and whether it's biventricular or univentricular involvement, as well as identifying subphenotypes such as myocarditis, SCAD, and other important shock modifiers such as cardiac arrest, respiratory failure, and ventricular arrhythmia, to name a few. We would then determine the severity of the shock based on the SCAI shock stage, and then from this determine support needs, whether that be purely inotropic and or mechanical circulatory support. The team would then determine patient's candidacy for circulatory support and identify anticipated exit strategies and develop a plan if they were not otherwise a candidate for MCS. The team would then help determine the type and facilitate the placement of a mechanical circulatory supply if deemed necessary, and then would help in determining the patient's destination following MCS deployment, after which there would be documentation in a standardized EPIC note that is being produced, and the care of these patients would be taken over by the accepting unit, whether that be the CICU or the CTICU, depending on the device type that they receive, and with the team being available for reactivation if the patient shows evidence of further decline. So just to look at the roles for this group here of the interventionalists in this team. So in patients that come into the cath lab immediately, typically with STEMI and AMI shock, which does make up here so far approximately 50% of the shock population, so 40 of those 80 patients in the past year did present with AMI shock. It would be involvement. It would be assessment of the need for and performing coronary angiography and PCI. they would be involved in the assessment of need for and deployment of percutaneous mechanical circulatory support devices, and in the assessment and need for performing percutaneous valve interventions if deemed necessary, among other interventions that may need to be performed. In patients that are outside of the cath lab, initially, the interventionist also would assist in placement and interpretation of patients' hemodynamics, which again also would occur in the cath lab. And yeah, that is pretty much it. Was where I was going to stop. So I guess the next part I was just going to ask for was if there are any questions about this process, and or just further discussion about the mechanics of this team and how it's going to fit in with the workflow down in the cath lab.
Thanks, Alex. I think that was very helpful. I mean, did you get a sense when you've been working on trying to, build some of these protocols, what has, and maybe some of the faculty who've been here longer than me can also chime in, what had the process been here in the past for these types of patients, and what previous attempts have there been, and any learning that we can incorporate from that?
Yeah, so I know that in the past that there had been, I think in like 2018, there had been a team working to develop a cardiogenic shock team. And I think that they initially had started on a very broad scale and started throughout the entire hospital. And I think that also due to COVID in some sense, I think that the team had sort of fizzled out. And I think that that was in large part due to there being there's less classification of these patients. So it was much more variable in how these patients would be managed. We now have SkyStock stages and many other institutions that have utilized and published on protocols and management techniques that have been done. And I think because of that, we're sort of, I think, poised in some way for hopefully more success this time around.
Hey, Yusuf, this is Steve. I will just comment on the experience pre-COVID. Lavi, Bell, and Conda had worked kind of hard to try to put this together. And my own personal experience is that the buy-in from the heart failure folks and cardiac surgery was very variable. Some people were really committed, and other people were, just to say, less committed, and kind of the cohesiveness wasn't really there. So it was a great idea, but its translation or its practical execution was kind of limited by people's commitment at 2 o'clock in the morning to kind of come in and make those evaluations. So I think the big thing, and Alex certainly has enough energy for all of us, that to have somebody who's kind of committed to getting everybody to really buy in and participate fully.
Alex, have you, to echo what Steve said, I think the variability was enormous in the past. So,
Yeah.
how, and I think even amongst interventional cardiologists. So, an acute MI that we just talked about. Similarly, what happens to a patient who's, post-op from surgery who develops cardiogenic shock and they want to put them on ECMO, because that's, a large percentage of our patients who are on ECMO, or a patient who's undergoing, who has advanced heart failure and they're considering, LVADs, et cetera. I'm curious, maybe you can share with the group, or maybe you haven't yet, sort of the buy-in from surgery and heart failure and how they envision this for their patients, and et cetera. I think there is, from our experience, a lot of variability, how each surgeon may want to manage a patient, or how each heart failure doc may want to manage a patient. And that can make challenges when you're trying to put together something like this, when, there are individual providers who are the attendings on the patients.
Yeah, definitely. So I have spoken with the surgery group multiple times, including earlier this morning, as well as the heart failure providers sort of very, very frequently. And I will say that I think this time around there's definitely very significant buy-in from all of the heart failure providers for this team. And I think that in many ways they are all thinking in a much more cohesive manner currently in how they think about deploying mechanical circulatory support. But it is very challenging to put together a very prescriptive model for this because there's such significant variability in patients, their hemodynamics, and just patient phenotypes that are seen here as the etiology of their shock. And because of that, I think it's hard to be entirely prescriptive, but there is a relatively solid core group here that is very invested in this and very committed to this now. And I think that that very much will help our outcomes and help our performance in executing this team. Similarly, the cardiac surgeons are also very interested in this team and are interested in improving our outcomes. I just spoke with them earlier this morning during their faculty meeting, and I think that the post-cardiotomy patients are a separate population that will likely, this shock team will not be so explicitly involved in. This will likely mostly be the AMI and heart failure patients. There will be some crossover with that population, but in some ways that's a sort of a unique entity that I think they like to manage themselves. So as far as the heart failure and AMI patients, the cardiac surgeons are heavily involved and are planning on being heavily involved. And it's a relatively small group of providers that will be involved with this team. So there will be, I think, good consistency and therefore good consistency in the care that's delivered.
And Alex, what for the surgical side, are all of the surgeons contributing to the on call for this, or is it a smaller pool? I know for interventional it's going to be whoever's on call for STEMI, and for heart failure I think it's whoever's on call for heart failure 1, which is the transplant
LVAD attending.
service. Yep. What's the plan for surgery?
So from the surgical side, it could potentially involve all of the surgical providers. However, it is primarily going to be just the providers that's on for heart failure and transplant, which is typically only a cycle of 3 providers or so currently. Predominantly Dr. Davis, as well as Dr. Onwer and Dr. Gearson are the 3 main people that will be involved with this and who we have good buy-in from all of.
And so from our perspective as an interventional group, there's no sort of additional call burden, as it were. It's whoever's, on call for STEMI. And then I think you're probably envisioning in the first rollout, a lot of the activations were going to be cath lab based.
Yeah, I think exactly. I think a lot of the activations will be cath lab based, just because that's when ideally we'll be having some form of hemodynamic assessment before activation of this team. However, those activations for patients coming from the CICU and coming from the floor the discussion will come from the team that sent them down, as opposed to patients that were otherwise immediately presented to the cath lab.
And can you just
can I interrupt? It's Ed from Bridgeport. So we've been trying to kind of get this going, at least in a smaller model at Bridgeport. And I've had patients that you recognize that you need, you put an Impella in and you need the next level. And we have ECMO now at Bridgeport. We just can't keep the patients there. But I think it'd be good if we were a little more involved earlier, since we have a number of operators who are good at large bore access and can kind of participate in this process. The problem is, like, I called Yale to try to find out who could do ECMO, and like they're like, okay, and then Brian Malm called back because they thought I said echo, and
Gotcha.
It takes like, a long time. So if we can have kind of like some involvement and partial access into this, but my impediment's been, I think, the same as a lot of you guys is, getting people to recognize that the patient's a shock patient coming to the lab, not, just a STEMI. And, we had a case, of a ruptured pap muscle, a couple of days ago. And, you have to have the right heart cath up front, look at what you're doing. And, people are still depending on balloon pumps, when the cardiac index is, 1 or 1.5, and I think if we do things, I think pushing the algorithm and making people think about doing a right heart cath up front, even when they're like confronting an anterior STEMI or something like that, we're gonna have to change the culture a little bit for all the operators. And but I want to drive that as well at Bridgeport.
Yeah, I actually think that's probably going to be, the number one change to workflow for the interventional portion is more of an emphasis on doing these hemodynamic assessments. Because for Alex, from the way you're describing it, the majority of the time the team shouldn't be activated until we have a hemodynamic assessment. And so, moving the right heart cath a little bit higher up in our minds for these patients, it's not, not just the fulminant shock patients, the ones that are, a little bit borderline or big anterior and, blood pressure doesn't get much above 100, just emphasizing, doing the right heart cath earlier. And then Alex,
I don't know if Jepta or anyone is on that can talk about door to balloon time with, if somebody comes into the anterior STEMI and hypotension, can we put a balloon or a right heart cath and then take a second, activate the shock team, and let's say we're worried about a ruptured pap muscle, before we go putting wires down the coronaries. How does cardiogenic shock factor into door to balloon time metrics?
That's a good question. I don't know the answer to, but
So
maybe we should take the shock patients
what I would
off
say
of
is
off the door to balloon times, because that's the same argument we get at Bridgeport is get in and just get the artery open. And, you sit there, you can spend an hour opening the artery while the patient's in progressive shock and not perfusing because you didn't recognize how bad it was. And I've done that. And I'm sure everyone's had cases like that.
Yeah, I mean, there's not evidence that putting in a swan is going to help patients' outcomes. And so I don't think we should be delaying reperfusion to put in a swan. I think the real question which is why, because this is the majority of patients that we will see are going in the cath lab, especially after hours, are going to those. I think we need to have a bit of a discussion about whether that's something that happens in parallel, so that if you have a patient and you're diving in and the patient's in shock in the ER on pressors with the inferior and anterior STEMI, the cath lab is obviously activated and coming to do that. It would not be unreasonable for at the same time for the shock team to be activated. Obviously, the cath lab will get there first and will be working to facilitate opening the vessel. But after that vessel is opened, if the shock team is there and the vessel's opened and a swan can be put in to decide what the next should be, I think having those processes started in parallel would be much better than starting them in sequence and waiting till the vessel's opened and then you've put a balloon pump in and then you're deciding what to do. But I think that's what needs to be done, because the interventionalist can't be on the phone doing it. It would need to be people saying, okay, we're going to come in and evaluate and we know what's going on. But that's where there's been some challenges before, because it requires a heart failure doc who wants to come in, or an intensivist who wants to clarify how that's going to work.
I think a lot of it is going to depend on the time of day. If it's I think the aim for the team is that in working hours these should be bedside assessments, and that if the patient's going to the lab, that the components of the team beyond the interventionist should be convening in the cath lab. And like John says, reassess the hemodynamics, after the vessel's open, and then decide on the next steps there. I think where it's going to become harder is when it's in the middle of the night. We're not, it's going to be, with the best will in the world, difficult to convene a bedside assessment in the middle of the night for these patients.
Hey, Alex, real quick question. For
Yeah.
patients that are not coming to the lab, so the patient in the CCU or on the floor that's in shock, has there been any discussion about increasing the capabilities of placing a SWAN in the unit like most other centers do?
Yeah, no, I know that Elliot has been, or Dr. Miller has been very interested in sort of pushing what can be done in the CICU. I think that it'll take some time to make some of those things happen. But that is definitely something that is in discussion and in the works, because I think there's this very large role for that. It's just the process of getting that sort of up and running and done. But yes, that's definitely something very much on the front of my mind and the front of other providers' minds.
So, Alex, there's no hospital policy that says that SWAN can't be placed at a bedside in a unit. Just to be clear, it can be done.
Okay.
It's been done. So I think you may get pushback from some nurses and other, but I went through this. I've gone through this on numerous times. A SWAN can be placed at the bedside in the ICU, and there is no policy against it.
So we will work on that. Yes, making sure that those that is sort of like a capability that we have, so we can get those done. I guess just another point that I just wanted to sort of to highlight about this team is that obviously, as sort of the discussion has gone on, there's a lot of variability in how these patients are presenting and in many different stages of shock, and that whenever there is thoughts about activating the team, especially in the lab, I would just consider immediate early activation of this team, as Dr. Forrest had said. I think that is what is going to lead to better outcomes for these patients. And I think that is sort of the goal of this team, is to be there right up front when they're needed, so that we can help immediately for everyone, so that no one's left alone to deal with everything, so that we can be a resource and so we can help improve the care of these patients.
And then I guess, Alex, have you maybe you reach out to Ed to discuss speaking to the Bridgeport in a separate session as well?
Yeah, definitely. I think if their group is much more on sort of the forefront of this compared to other affiliate hospitals, then yeah, I think that process should get going. Definitely. So I will reach out to Dr. Tui. All right.
That was a great discussion. Good job, Alex, and thank you everyone for logging on.
Thank you.